Hello and welcome to Aging Well with Dr. Bob. I'm Dr. Bob Flaherty. I'm a family physician, and in a previous presentation called Decisions at the End of Life Part 1 Important Documents, I discussed the Healthcare Power of Attorney, the Advance Directive or Living Will, and the Portable Order for Life-Sustaining Treatment or POLST. Today I'll be discussing Decisions at the End of Life Part 2, Palliative Care, Hospice, and Medical Aid in Dying. As we near the end of our lives, we will likely face several medical decisions relating to options at the end of life, including palliative care, hospice, and medical aid in dying. In today's presentation, you will learn more about these options and when you might consider them. References are given at the bottom of most slides. This presentation is for information only. If you have any questions, be sure to discuss them with your doctor, physician assistant, or nurse practitioner. Shakespeare said, "Death, a necessary end, will come when it will come." Indeed, it will for all of us. But today I want to talk about some things that might help us as we reach the end of our lives. The first option to think about is palliative care. This is the active total care of patients whose disease is not responsive to curative treatment. That is to say, this occurs when we reach a point where curative treatments are not working. The point of palliative care is to improve a patient's quality of life. And palliative care supports the physical, psychosocial, and spiritual beliefs of patients and families. To put it another way, the goal of palliative care is to relieve suffering and provide the best possible quality of life for patients and their families at any time during the progression of a serious disease. And this is not just for cancer. It also includes heart disease, dementia, Parkinson's disease, lung disease, stroke, chronic kidney disease, cirrhosis, and Lou Gehrig's disease. Palliative care is available to patients at any time from the onset of a serious diagnosis, so that a patient doesn't have to be necessarily terminal. And also, palliative care is not time limited in the duration that it can be provided. And you can continue to receive curative treatments while receiving palliative care. The providers of palliative care depend on the need and can include primary care doctors and specialists, special palliative care specialist doctors and nurses, medical social workers, nutritionists, chaplains, and also family members. Services depend on the illness, but the focus is always on quality of life. For example, a patient with serious COPD or emphysema could receive active treatment of shortness of breath, fatigue, pain, anxiety or depression, and also receive social support, some support for the burden of caregiving, support for their spiritual needs, and always a focus on dignity. Palliative care can be provided in the home or in an assisted living facility, a long-term facility or a nursing home, or also in the clinic or hospital, or in a hospice facility. The next option to consider at the end of life is hospice. This is a specialized type of healthcare specifically designed for the end of life, a time when a significant decline in physical and or cognitive status occurs despite medical treatment. That significant decline may include increased pain or other symptoms, substantial weight loss, extreme fatigue, shortness of breath, or weakness. No further treatment of the terminal disease occurs. This is more intensive and more comprehensive than palliative care. Hospice focuses on improving the quality of life at the end of life. This will include comfort care, relieving pain and other symptoms. also addressing emotional and spiritual needs. And it can be thought of as palliative care plus, more intense, more comprehensive. Hospice care uses a specialized care team that includes a hospice physician, hospice nurse, medical social worker, a home health aide, a chaplain or spiritual advisor, and also includes the family members. And hospice can occur in your home, nursing home, or a hospice facility. Some key points about hospice include these. Death must be likely within 6 months. And hospice is not just for cancer. It can be for any terminal illness. For example, for heart disease, dementia, Parkinson's disease, lung disease, stroke, chronic kidney disease, cirrhosis, or Lou Gehrig's disease, or ALS. And in fact, in 2021, only 24% of hospice patients had cancer. Hospice care is almost completely covered by Medicare because it's less expensive to be treated in a hospice situation than in an emergency room or with hospital admissions. You can find and compare hospices at this website, www.medicare.gov/care-compare, or ask your healthcare provider about their experience with local hospice organizations. A problem with hospice is that it's underutilized. For example, 10% of hospice patients are only enrolled in hospice for 2 days or less before they die. 25% of hospice patients are enrolled for only 5 days or less before they die. 50%, 17 days or less. And 75% of hospice patients are enrolled only 79 days before they die. This is even though hospice is designed for the final 6 months of life. And this underutilization means that patients are losing out on the many benefits of hospice. The difference between palliative care and hospice care can be a little confusing. Palliative care is focused on serious or advanced illness, but not at the end of life, whereas hospice is focused on terminal disease in patients who are going to die within 6 months. I've explained the difference between palliative care and hospice care to my patients, in that palliative care makes living easier. Hospice makes dying easier. A third consideration at the end of life is medical aid in dying. This is also called medically assisted suicide or death with dignity. The key point is that the patient decides and asks the physician for life-ending medication. This is not euthanasia. In euthanasia, the physician decides to end the patient's life. The key point in medical aid in dying is who makes the decision. Medical aid in dying is not considered suicide. Kathleen Tucker reviewed the experience of medical aid in dying in Montana and said that many national medical, mental health, and public health professional organizations have considered this issue and determined that a death through medical aid in dying is no sort of suicide and ought not to be confused or conflated with suicide. The key difference between medical aid in dying and suicide is that suicide is considered to result from a mental illness. And in fact, medical aid in dying requires that the patient not have depression or other mental illness, but be competent in making a decision. Medical aid in dying is legal in several states. As of 2024, it's legal in California, Colorado, District of Columbia, Hawaii, Maine, New Jersey, New Mexico, Oregon, Vermont, and Washington, and also legal in Montana. And I'm going to focus for a few minutes on Montana, where I've practiced medicine. But the information for Montana applies to most of these other states. Medical aid in dying in Montana is legal in Montana because of a Montana Supreme Court decision in 2009, and also because of legislation called the Rights of the Terminally Ill Act. Several bills have come through the Montana legislature to overturn medical aid in dying, but they have so far been unsuccessful. In Montana, and in most other states that allow medical aid in dying, the procedure is as follows. To request a prescription for life-ending medication, the patient must be at least 18 years old. They must be terminally ill, that is, less than 6 months to live. They must be mentally competent and no evidence of a mental illness, and they must be able to self-administer the prescribed medication. Note the patient requests a prescription and administers the medication themselves. In most states, 2 doctors must attest that the patient qualifies for medical aid in dying, and these requirements are similar in other states that allow medical aid in dying. There are safeguards to medical aid in dying in Montana and in the other states that allow medical aid in dying. The attending physician must inform the patient about all other end-of-life care options, including comfort care, hospice care, pain control, and palliative care. The physician must inform the patient that they can change their mind at any time, and the physician must offer the patient an opportunity to rescind their request. The number of cases of medical aid in dying in Montana each year is unknown. There's no requirement to report. They're probably not reported as death due to suicide, but due to the underlying disease. And this may also be the case of reporting in other states. There are several methods for medical aid in dying. The first and easiest is simply stopping life-sustaining medications or therapies like a pacemaker. And patients have the legal right to stop any treatment. Prescription medications is another method. This is where a physician, and it's only a physician that can do this, not a nurse practitioner or a physician assistant, but where a prescription is written by a physician for 2 anti-nausea drugs given 1 hour before, and then a combination of a narcotic plus 2 sedatives plus 2 cardiotoxic drugs. In this situation, the patient generally falls asleep within 2 to 10 minutes, and the heart stops within 20 minutes to 2 hours. Another method for medical aid in dying is voluntary stopping of eating and drinking, or VSED. This is where the patient takes absolutely no fluids or food, not even ice chips. Medications can be provided by the physician to relieve hunger and thirst. However, this can take days to a couple of weeks, depending on the underlying fitness of the patient. This is, however, legal in all states. The U.S. Supreme Court has ruled that a competent person would have a constitutionally protected right to refuse life-saving hydration and nutrition. For more information about palliative care, hospice, medical aid in dying, talk to your doctor, your physician assistant, or your nurse practitioner. And other resources on these topics are on this slide, and I'll leave it up for a minute so you can write these down. Thank you for watching this presentation. I hope you found it informative and helpful. If you did, please click like below and subscribe to keep up to date with new presentations. and be sure to check out Decisions at the End of Life Part 1, Important Documents, on this Aging Well with Dr. Bob YouTube channel. Best wishes and age well.